As a pediatrician from Pakistan, I care deeply about the issues that you are discussing in this conference. It is incredibly sad and truly unacceptable that we still live in a world where millions of children and pregnant women die or are permanently disabled every year due to entirely preventable causes. We have lost momentum on the hard-earned progress for maternal and newborn health. There is no doubt about it. But all of you have the chance to regain this ground and more through your actions. Healthy women and healthy children are central to the well-being and strength of families, communities, and economies. That's why at the Gates Foundation, our vision of a more resilient and equitable world starts with healthy mothers delivering healthy babies. I'm encouraged to see many parts of the maternal and newborn health community joining forces, sharing insights, and amplifying your impact. Together, we have the incredible opportunity and privilege to save the lives of so many mothers and babies by delivering quality maternal and newborn health services everywhere. While I'm typically one to see the glass half full, it's important to take stock of where we are right now so we can achieve what I believe is possible in the future. As everyone here knows, we need a much stronger and clearer focus on maternal and newborn health. We are not on track to meet our SDG targets. Women and children are facing life-altering complications or dying unnecessarily every day, and progress must be accelerated. Furthermore, when we dig deep into the data, we are seeing that many effective drugs, products, and life-saving interventions are not reaching the mothers and babies who need them most. This is, in part, exacerbated by the fact that we are facing a global shortage of millions of midwives and healthcare workers. We are truly at a critical inflection point. But the optimist in me sees a brighter part ahead. The good news is we already have many of the innovative tools and practices that work, from immediate kangaroo mother care and maternal azithromycin to quality midwifery care. Now is the time to put all of these ideas into action by scaling efforts and maintaining quality as we scale. At the same time, we still need better data, new technologies, and novel approaches if we are to prevent further backsliding. We need to make products and services more available and more responsive to the varying needs of mothers and babies. We need health workers to be able to provide care in a well-functioning, well-equipped, well-stocked, and dignified environment. And of course, we need women's voices and women's leadership at the center of our collective efforts. I've seen firsthand what we can achieve when we have all of these things: the right people in place, enabled by the right processes, the right products, and the right environment. We know that when donors and countries invest in maternal and newborn health and nutrition, it doesn't just improve the lives of women and children. It unleashes a powerful engine for progress that can build more prosperous economies, reduce poverty, and advance gender equality. I love the quote by the anthropologist Margaret Mead: "Never believe that a few caring people can't change the world, for indeed, that's all who ever have." This conference of a few caring, bold, and dedicated people can and will make this happen. As you've heard, this is not just a moment. This is a movement. I am there with you in spirit and solidarity today and every day as a member of this joined-up community. We can end preventable maternal and newborn deaths in a generation, and it will take all of us working together to make it happen. Thank you for being here, and thank you so very much for the work that you do every single day.
Distinguished colleagues and conference members, Assalamu alaikum. I am Samrina Siddiqui, a mother and an Afghan midwife with 15 years of experience in this field. Even in the most remote and hard-to-reach areas of Afghanistan, midwives are trusted providers supporting women and their families across the continuum of care. Through OFIAT, we have introduced a new approach, the group-based antenatal and postnatal model of care, which offers participating women a sense of community and sisterhood. The approach focuses on supporting women as they share in groups their concerns and challenges. During the session, mothers learn about many topics to keep them healthy during pregnancy and postpartum. The midwife also helps them conduct self-assessment, screens them for prenatal depression, and gives an individual checkups to help connect them to the right care at the right time. Women come to the session with the permission and support of their husbands, and some first-time mothers come with their mothers-in-law who are also interested in learning about these topics. Engaging families has helped to improve attendance at ANC and PNC visits. Participants mentioned that they had no period information about safe pregnancy or childbirth, and they did not dare to ask their mother or mother-in-law or others, but through participating in these sessions, they felt more confident and knowledgeable about their pregnancy. Seeing how this approach is empowering mothers who are regularly following their scheduled ANC and PNC visits feels great. At a time when Afghan women are increasingly isolated, midwives are empowering mothers and their families with the right information, quality health services, and safe spaces to discuss challenges and share experiences with each other. This is a core of the quality of care and makes both patient and midwives more resilient. We cannot stop our work. We cannot take a break. The efforts to strengthen midwives must continue to ensure that all pregnant women, mothers, and their babies in Afghanistan receive the high-quality care that they deserve. Thank you all for your commitment to quality of care. I wish you a productive session.
Good afternoon, everybody. Are you guys awake after lunch? Yeah? Good. Good to hear it. Welcome back to our plenary stage. My name's Deborah Charles, and I'll be your moderator again this afternoon. And in this room today, we've been talking about the big challenges and roadblocks faced by the maternal newborn health community. This morning, we talked about how to prioritize and finance MNH, and this afternoon, we're going to be tackling another big topic, one of the big challenges, and that's how to ensure quality of care. How do we make sure that mothers and babies get the best possible care to reduce maternal and newborn fatalities? And what's the best way to build strong systems to deliver quality MNH services? And what is needed in order to deliver quality at scale? So here's the plan for today's session. First, we get an overview of the issue from the amazing, omnipresent Dr. Queen Dubé. Then a panel of experts will come up to the couches and have an intimate conversation with all of you listening in. And they'll tell us about their experiences and lessons learned about quality of care, as well as what they see we need to do that needs to continue to be improved. And finally, we'll hear from a parent advocate, Wanjiru Kihusa, who will help bring things back to where we need to focus ourselves anyway. The patient, the parent, interaction with the patient and parent. Okay, so let's get started. And now I am pleased to introduce a woman who doesn't really need any introduction, but I'm going to introduce her anyway. Dr. Queen Dubé is a pediatrician and a clinical epidemiologist who is Chief of Health Services at Malawi's Ministry of Health, and she's also one of the co-chairs of the Align MNH Steering Committee. With that, Dr. Queen.
Good afternoon. I do have a very difficult task to give this first talk on this plenary, very important plenary, immediately after lunch, when there's a little fight between your gut and your brain. So for just an hour, I will ask you to overcome that fight by putting all your energy to your brain. This session is about quality. We started yesterday looking at our data. And this figure of 4.3 million deaths annually, we heard it over and over and over again. We heard it on Saturday, Sunday, Monday, Tuesday, today is Wednesday. But when you look at that figure, 4.5 million deaths every year, 0.28 million are women, mothers. 1.9 million are stillbirths. Sometimes when you look at a figure and then you put a face, I was very struck with Treasure's story yesterday. And when I went to my room, I kept on thinking, within that 1.9 million, those are so many little Moeses. Maybe some of them are little Esthers. But that 1.9 million number, there are faces behind it. And we also have 2.3 million deaths. Yesterday and the whole of today, we keep on emphasizing that this is not just a moment, it is a movement to try and arrest these high astronomical figures. I was speaking to Her Excellency, the Minister of Health for Liberia, and she was talking about the population of Liberia being 5 million. Now, if you think about a country like Liberia, that in a year the whole country is wiped out. That's the magnitude of the figures that we're talking about. Now, yesterday we also had exciting presentations from Gaga and Alison showing us a progress, where we are now, where we still have deficiencies. And if you remember some of the slides, we seem to be doing pretty well on some of our coverage indicators. But we have plateaued on the maternal, stillbirth, and neonatal agenda. So coverage on its own is not enough. For us to get the impact that we need to mix the coverage and quality. This marriage must work for us to have impact. Now, we know in terms of when you look at evidence, scientific evidence, where we're supposed to put all our efforts. Now, when you look at pregnancy care, so this is where our first 90 is. When you look at pregnancy care, so we're talking about focused antenatal care, we're saying at least 90% of our pregnant women have at least 4 quality ANC visits. Birth care, we're talking about at least 90% facility births. Postnatal care, it's 80%. And then newborn care in hospitals, we're talking about level 2 care. It's 80%. Now, you see, many times when we're reporting from our countries, when you ask me about Malawi, for level 2 care, small and sick newborn, I will say, yes, we are even beyond 80%. But what is it that is in the 80%? When a woman comes to deliver at a facility, what type of care are we monitoring them? Do they have blood pressure checks? Are we doing fetal monitoring? So it is not just a figure. Quality is about what goes within the figure. All of us, I'm preaching to the already converted. When you look at this, this is a WHO framework on quality of care. It talks about the experience of care and the provision of care. And yesterday morning, Treasure went really deep into the experience of care. So quality is not just us ticking the boxes, but how do our clients, our mothers and our babies, feel about the care that we're providing? Now, when you deep dive into the low resource setting, where the highest burden is, we do have an estimated 2 million lives a year that could be saved if we only closed the quality gap. 2 million lives. So think about the 4.5. If we only closed the quality gap, we would be able to save 2 million. And you know what? There will be even much more impact on the stillbirth agenda if we only closed the quality gap. Now, quality is not just about the AQI project somewhere. Quality is more than QI. Quality demands a systems approach. And at the center of whatever we're doing are families, mothers with their babies. And the question is, how can we get faster progress? A few thoughts that I wanted to share. We've been talking about aligning together, accelerating together, and saving lives together. So we really need to move away from this fragmented vertical approach, where HBB is running on its own, Essential Newborn Care is running on its own, ANC is running on its own, PNC is running on its own. What really matters for that pregnant woman is not all these crazy titles. What really matters is that they get the care that they were supposed to get. They go home alive with a healthy, bouncing baby. That's what matters. So an integrated plan, investment into maternal and newborn. If you look at our friends, our colleagues in the HIV field, they will not take no for an answer. We know the things that we did between 2000 and 2010 that got us to where we are today. If we continued doing the same things, we will not be able to hit the SDG targets. We need to do the harder things. And those harder things, an integrated plan, an aligned plan is important, but we need money. We need value for money. Where is the money that we're putting in the MNH space going? How much of that is going towards administrative costs? And how much is truly going to that pregnant woman and their mother? We really need to rethink how we're implementing. And we need to start to invest in data systems. Look at impact at that subnational level and national level. Welcome once again to the quality movement. Together we can.
Thank you so much, Dr. Queen. Now I'd like to welcome the panel and introduce our moderator of the panel, Neha Mankani, a midwife and founder of the Mama Baby Fund, a financial emergency fund for maternal and neonatal healthcare in Pakistan.
Thank you. So as Debbie said, I'm a midwife by profession. I work in Pakistan, and I can say, I think for a fact, I can speak for all midwives when I say that it's actually very hard being a healthcare provider. It's not easy. Being a midwife is not easy. It's a very difficult job. And I've never met any healthcare providers who haven't wanted to be good at what they do. Everyone wants to provide quality healthcare. I was part of a class when I was studying to be a midwife. There were 25 student midwives in my class, and I think now, 10 years later, maybe 5 of them are still practicing. And I'd often ask them, you know, in a place like Pakistan, why don't you want to keep working? And the answers were always around, it was just too hard. It was too difficult. We weren't able to do our job because we didn't feel safe, we didn't feel confident, we didn't feel like we had enough skills. There was no oxytocin at the facility. We didn't have any water where we worked. Like, we just were not, there were no medicines. We weren't able to do our job. And we saw this reflected in 2021. We saw this report come out, Midwives' Voices, Midwives' Demands, by the White Ribbon Alliance, ICM, and where 56,000 midwives from 101 countries were asked what it is that they needed. And this was, what we saw was just in line with this, that midwives wanted functional facilities, they wanted to be better supported, they wanted more human resources where they worked, they wanted to have the capacity to be better at their jobs, they wanted transport, and the summary was that they wanted to be able to provide quality care. If we talk about the flip side of it, as a midwife, I've worked at facilities, and one of the main things that we do is we need to have a very strong referral network in cases of emergencies for maternal and neonatal care. And I would often refer people to the nearest district hospital, and the answers that a lot of times women would turn around and say, I'm not going to go. I'm not going to go to this facility because I'm scared. This word of, I'm terrified of this facility, I'm not going to go. But then we started seeing people who were having adverse outcomes, baby's heart rate is dropping, and they would say, I would rather have an adverse outcome than go to this health facility. And I started unpacking what it meant to be terrified of a health facility, and it was all of the same things, that they were treated badly, they were disrespected, they had to share a bed with someone, they had heard about babies dying, there were no medicines, there was no clean water, there weren't trained healthcare providers. And it comes down to the same thing, that these are quality issues which become issues of access, acceptability, and safety. And as a healthcare provider, I will say that there are no bad healthcare providers, there's just really broken systems. And we'll talk a little bit more about these systems with this really wonderful panel here today. I'm going to start with Dr. Tegbar from Ethiopia. He is a public health physician with more than 2 decades of experience in program implementation, and his work, a lot of his work is around human resources for health and health workforce strengthening. So Dr. Tegbar, I'm going to start by asking you that as a healthcare provider, as you heard, I always focus on the role of healthcare providers in delivering quality care. And in Ethiopia, we've seen that all the way from health extension workers to the referral level, there has been a lot of really good progress. So how do you make sure that the health workforce is available and equipped to provide healthcare services?
Thank you very much. Can you hear me? So, I mean, globally, we know there is no healthcare without healthcare worker. So any drive to improve quality of care should bring, the issue of health workforce front and center. And when you talk about health workforce, there are important dimensions. The first one is, do we have adequate number of healthcare workers? The second one is, are they accessible to all segments of the population, which is about equitable distribution? The third one is, do they have the skills, competence, and behaviors required to provide high quality care? And the fourth one is, are they acceptable to the community they are going to provide service? So if we take that perspective and apply or examine what Ethiopia has been able to achieve in the last 2 decades, 10 years ago, Ethiopia had less than 4,000 midwives. Now, Ethiopia has more than 20,000 midwives, a 5-fold increase. This is the same across all cadres. I can tell you the number of doctors also in the last decade has increased by more than 5-fold. If we look at the workforce density, the health worker to population ratio in Ethiopia in the last 10 years has increased from 4 to 8 doctor, nurses, and midwives per 1,000 population. So has doubled, taking into account, the increase in population number. It's not just increases the number of healthcare workers. Ethiopia has also made good progress in improving the maldistribution of the health workforce. Again, if we look at data 10 years ago, the region with the highest density of healthcare workers had 10 times more healthcare workers than the region with the lowest or fewest number of healthcare workers. That differential has now dropped to 3. Again, these are the result of a number of important policy choices in increasing training capacity, in locally recruiting and training healthcare workers, task shifting, expanding training capacity in training institutions, a number of strategies, supported by a national HR strategic plan within the scope of a national health sector development and transformation plan.
Okay, thank you. We'll go on to Dr. Swaraj. She is Chief OBGYN at Nidan Hospital in Nepal, and she has a lot of extensive experience in clinical and technical leadership and maternal, neonatal, and reproductive health. Dr. Swaraj has worked a lot on integrated quality reproductive health spaces and the policy space specifically, and we heard Dr. Tegbar talk about the importance of policies. So, Dr. Swaraj, I'd like to ask you, what is your understanding of how all of these national standards, policies, and protocols how do they translate to increase in quality care?
Thank you, Neha, for your question. Good afternoon and namaste to all of you. The World Health Organization states a vision that every woman, child, and adolescent should get the quality services throughout their life. And to operationalize this, the WHO guidelines, many countries have adopted these standards, policies, and protocols as per the context, country context, as per their need. So the focus has been that to improve the quality of maternal and neonatal health, lots of guidelines have been developed and adopted. Now, when you say the supportive policy, I would say the advocacy is the key. We have to do the advocacy to the policymakers, managers, and the service providers based on the evidence-based guidelines and all those things. So once the policy is in place, the role of the stakeholders comes in. Why stakeholders' role is important, especially in the developing country like ours, it's very challenging, the health situation, to make them like inclusive and equitable, and also to make them like to take the ownership. And that's why the role of stakeholder really plays a crucial point. So I'll just give an example how the policy we can implement to the field level. I'll give an example of developing skilled birth attendant learning resource package in our country. So all the partners came together, all the development partners and the professional organizations, we developed the learning resource package to give the quality service. At the same time, QI tool indicators were also adopted so that realistically attainable standards are implemented. So now, the government of Nepal has been trying to improve the quality of care in various implementation plan. One of the example I would like to say that in 7 remote districts, with the support of GIZ, we did use the same tool what we had developed, but the nurses who got training, we went to the field and we saw whether they have the baseline equipments, everything, the facility, and then whether they have the signal function is working for BMOC and CMOC. And then after a couple of months of the follow-up, what we noted was, I think when they saw the score not going to the green, they are still on the red and the yellow. So they were all very motivated to work in that matter. So what they needed was a little bit push and little bit support from the outsiders. And this was the very good experience that at the end of this couple of visit, we saw that they were really able to improve the services because the mentoring on site was done based on the gaps, and also the logistics and equipments were provided. So another example I will give is that the minimum service standard has been implemented now, and this is based on the 13 existing gaps of quality to improve the health facility on the whole. Previously, we were focusing on the maternal and neonatal health. Now it is the whole of the hospital. And this has shown that it is a self and joint assessment, and there was a competition among the hospitals so that they want to prove that they are doing well than others and getting better scores. So the most important thing is that we're able to introduce the e-billing system, electronic medical records, and improve the services. And another point I wanted to highlight is here that the financial sustainability is very important, and they were able to do that because the 24 hours pharmacy services, and they were selling their waste, from the waste management, they were selling the waste products. So this way, we see that this is also one of the sustainable program. And lastly, I would like to mention about the MPDSR introduction. That is also to improve the quality. However, having said that, it is not all the bed of roses. There are some challenges because in the Nepal, we are devolving the structure now. We are the federal structure. So I think in the central, we are in place. But then when you go to the local government, I think we need to embed this quality of improvement into the local government. And for that, we are working very hard to develop the capacity. Thank you.
Thank you, Dr. Swaraj. It's really interesting to see how policies are really important, but how they actually translate and how important feedback loops have been and working with service providers and also the challenges you've experienced. So thank you for that. I'm going to move on to Asir Minungu, who is the Executive Director of ACAME. So ACAME is the African Association of Medical Store. And Asir has worked extensively in African countries on reform around medical store and procurement processes, which is, so ACAME has been increasing access and availability of healthcare products and supplies, which, as we know, are a really big gap that we've seen in many places and a very important part of the quality puzzle. So I'd like to ask you, Asir, even with a highly skilled workforce and supportive policies, data, and protocols, as we heard from Dr. Swaraj, we cannot deliver care without products. So we need medicines, we need equipments, we need infrastructure. So can you tell me that as we think about delivering essential medicines, how does ACAME improve the quality of care for the countries that it works in?
Thank you. Allow me to give the first part of the answer in English and the second part in French. Firstly, allow me to explain what is ACAME. ACAME is a network of national medical store or national medical agencies in Africa. We have been created in 1996 after the devaluation of our currency, which impact the accessibility of essential medicine in Africa. In the beginning, we was 5 countries, but now, in this year, we bring together 22 countries in Africa, from Algeria, north to south, Madagascar, Comoros, east to west, Senegal, Côte d'Ivoire, Burkina, to DRC, Djibouti, and so on. This is what we are, or who you are. For the second part of your question, I will give an answer in English, and I hope that the translation will do it best for everyone. Donc, je disais que en matière de facilitation de la disponibilité des médicaments en Afrique pour nous au sein du réseau de la CAM, qui regroupons donc les centrales d'achat de 22 pays, il y a 3 aspects importants que je voudrais souligner. Le premier aspect, c'est que nous sommes un réseau et donc nous partageons les bonnes pratiques, les bonnes expériences, et nous facilitons donc l'utilisation de standards internationaux tels que ceux qui sont produits par l'OMS, notamment le MQAS, Manual of Quality Assurance System, qui permet donc de garantir que les médicaments que nous achetons pour chacun des pays sont de qualité et répondent à l'ensemble de ces référentiels, à ces standards internationaux. Donc ça, c'est vraiment le premier aspect côté qualitatif sur lequel nous insistons et qui permet donc à tous ces pays africains, depuis 2012, nous sommes engagés dans ce processus de renforcer les capacités et de faciliter donc l'approvisionnement des médicaments de qualité. Le deuxième aspect sur lequel je voudrais insister aussi par rapport à la qualité, c'est la force de notre réseau. Donc nous sommes 22 pays et cela nous permet également de pouvoir lutter contre les ruptures de molécules, de médicaments dans les pays. Il peut y avoir un produit qui manque dans un pays A. Nous avons la capacité, dans des délais très brefs, par voie aérienne, de redéployer le produit qui est en manque d'un pays à un autre. Donc c'est la force du réseau, le fait que nous soyons 22 pays, le fait que nous partageons les mêmes référentiels d'achat, de stockage, de distribution des produits, cela nous facilite le redéploiement de ces stocks que nous appelons volontairement dans notre jargon le dépannage. Donc on se soutient, c'est de la coopération sud-sud qui permet donc de faciliter la disponibilité des médicaments de qualité et donc leur accessibilité au pays. Et je précise que quand nous supportons ce genre d'opération entre plusieurs pays, les frais, les coûts aériens de transport sont portés par la CAM. Parce qu'il faut faire en sorte que le médicament qui doit être rendu disponible pour les populations ne connaissent pas de hausse parce qu'il y a des frais d'approche qui sont imputés. Ça, c'est le deuxième aspect. Le troisième aspect est la force de notre réseau en étant donc, au sein de la CAM, côté qualitatif. C'est la capacité que nous avons de mettre en place des initiatives d'achat groupé, par exemple. Le fait que nous puissions mutualiser nos besoins en termes de molécules et d'avoir un seul mécanisme d'achat qualitatif, bien entendu, en intégrant l'effet volume, nous avons la possibilité de faire baisser jusqu'à un prix minimum raisonnable l'achat des produits et qui sera donc garanti en termes de disponibilité pour l'ensemble des populations sur le continent qui sont membres de notre réseau. Je voudrais terminer sur cet aspect pour dire que en tant que réseau de la CAM, nous contribuons également par le renforcement des capacités, parce qu'il faut reconnaître qu'il y a un besoin en termes de renforcement des capacités, il y a un besoin en termes de formation, et nous accompagnons tous ces 22 pays, notamment les professionnels qui interviennent dans la chaîne d'approvisionnement, à pouvoir avoir les compétences nécessaires par rapport à l'achat, au stockage et à la distribution des produits de santé. Donc, imaginez un mécanisme pareil que nous avons pu mettre en place après quelques années de création. Et nous travaillons de plus en plus avec les programmes PALU, VIH, TB. Si nous arrivons à mettre à l'échelle continentale ou régionale un mécanisme pareil qui puisse permettre de prépositionner, de disposer dans 2 ou 3 pays, que ce soit des stocks de sécurité ou alors d'avoir des mécanismes qui permettent de redéployer les produits de la santé maternelle et infantile, je crois que nous allons contribuer davantage à sauver des vies. Donc, qualitativement, voilà ce que je pourrais apporter comme élément de réponse à votre question. Je vous remercie.
Thank you so much, Asir. And I think just this procurement part is just really important. I mean, as a midwife, I've worked at so many healthcare facilities where we've just immediately seen a drop in uptake of services when we're not able to get medicines, especially essential life-saving medicines. So thank you for sharing the work of Akame. I'm going to come to Dr. Amit Thakur, who's the Executive Director of Africa Health Business, and he's done some really groundbreaking work in private sector integration and fostering effective public-private partnerships. And as we know that the role of the private sector is really important in quality of care. I know in a lot of countries, a lot of the healthcare sector is dependent on the private sector. In some countries, it's been greater than 50% of the care that's delivered by the private sector. So Dr. Amit, I'd like to ask you that how does a strong private sector deliver quality of care? How do you see that relationship?
Yeah, thank you, Neha. And I really want to thank the organizers for having private sector participate in this discussion. I met so many private sector institutions here from all different countries and different continents. Africa, a continent where I do a lot of work, over the past 30 years, 50% of the services in Africa for women healthcare and children healthcare are provided by the private sector. And I must clarify here that the private sector is the non-state health actor.
Exactly.
And anything non-state is, like you said, is half the player. And if you leave half the player out, you can't really strengthen a health system. And your question is very appropriate about how does the private sector play a role in improving quality of care. So as far as products and innovation is concerned, I think the private sector has done a tremendous job. It's led the way in R&D, it's looked at new drugs, it's looked at new products, it's looked at new solutions to save a mother's life, be it postpartum hemorrhage, or to make newborns survive longer through phototherapy innovations, and so on and so forth. You have seen many of them exhibiting here, and you'll see so many at the marketplace. So there is the whole product innovation side, that we can make a difference to the 4.3 million that Dr. Queen spoke about. But I want to touch a little bit on services. It's incredible how private sector is reaching the unreached mothers and children in far-flung areas across many continents, Africa especially. There are 3 main areas that I think could make this private sector do even better, so we have mothers living longer and the newborn surviving. And these 3 factors, Neha, are around regulation, financing, and incentives. If we created a regulatory landscape that is effective to ensure that quality standards are maintained, and you train clinics in primary healthcare, mid-level research facilities to continue abiding by the regulations of each country, it's incredible how many lives we'll save. And make sure that the regulatory landscape enables private sector to become better, not to take advantage of the gaps, but to make an impact in the lives. The second one is around financing. This may vary from continents to continents, but especially in Africa, where we saw 70% or so of maternal deaths, sub-Saharan Africa. If we just crack the financing puzzle and affordability through universal health coverage, through a mixed model, through a hybrid system, not only relying on tax, because it's definitely not sufficient. Through a blended, you will find that mothers will access care much easier than what they're doing now. A lot of the barriers that you see in the 4.3 million is financial. It's completely financial. Some opt to deliver at home because they couldn't go to the private sector simply because they're being asked for a deposit. And they're asked for, are you insured? And if they're not, out of pocket is the largest barrier in having women access this care. Today, in many countries, those who can afford are going to the private sector. If we did a poll of how many ministers of health seek care in the private sector and how many go to the public sector, that could be interesting. Just ask the 54 ministers of health in Africa that when you are, if you had to deliver, where would you deliver? And you'll be surprised at the poll results. And it's clear. And there is a reason. It's not, and the reason is that the financial gap is huge. Investments of equipment is huge. The third one, finally, I want to end up talking about is that we need to incentivize every provider, every facility across the entire globe on quality. We talk about quality in a way everybody nods their head, yes, we should improve quality, we should. But if we don't incentivize quality, does it really matter? And how do you incentivize quality? One is to actually ask the financiers to pay you more if your output in your facility is higher. If your cesarean section rates, your nosocomial infection rates, your take-home baby rates, and readmissions and repeat infections are better as a facility, we should incentivize that. Whether it's through an insurance, whether it's financial. I don't even know whether a star facility works. I mean, in hospitality, we see 5-star hotel. I don't know whether Westin is a 5-star hotel, but whatever it is. I wonder in healthcare if we start recognizing facilities across the world on maternal and newborn care, you might see many people surging towards making an effort in quality. It's not enough just to get JCI accreditation or boards, but we must incentivize, and I think that will change the 4.3 million numbers that we see. Thank you.
Thank you so much, Dr. Thakur. You've actually given us a lot to think about that, do we, especially around incentivization, that should this care be provided? I mean, it should be provided in high quality anyway, but what can we do to get better at this? So it's really interesting, and I feel specifically very strongly about the private sector because where I work, it's I'm bridging a very, very big gap that I've seen in maternal health through the clinic that I am running. But should I be bridging that gap? Is it the private sector's role to provide free healthcare where those gaps exist? So lots to think about. Thank you so much. But from that, I'd like to ask Dr. Swaraj what she thinks of the private sector and how protocols and policies come in over there, because we've also seen what can happen when the private sector is not regulated. So Dr. Swaraj, how do you see the role of protocols and policies in the delivery of care by the private sector?
Thank you, Neha. This is a tough question. I think all of us, we know that in low middle income countries, 1 in 5 deliveries occur in private sector, whether we like it or not, whether the government likes it or not. But I think we know there is the importance of experience of care for quality of care, and there has been no synthesis between the experience of care and the quality of care provided in the private sector. All of us, we know that. And recently, during the COVID-19, I think the private sector did a marvelous job. It's a phenomenal job they did to support the government. I think there was a lot of support during that. And I think I really would like to give hats off during that epidemic and pandemic. But regarding the day-to-day activity or day-to-day things, these protocols and the guidelines, is it easy to implement there? Definitely not. I find it very challenging. But I see the role of the professional organization here, as well as the role of NGO. Because professional organization can really play a mediator between the private sector as well as the government, because they work in the private sector as well as in public sector, and they also are in the professional organization. So I think they can play a big role. I'll just give an example, the role of the NGO, what they did. I mean, this is an old story, but I'll share anyway. So Nepal Fertility Care Center in Nepal is an NGO which works for family planning mostly. So they brought the networking of OBGYN, that is called Parivar Swasthya Seva Network, PSSN. And they kind of also did a paramedics network which would give the injectables, and the OBGYN would give the all family planning methods, as well as the IUCD and implants. So what they did, they standardized throughout all the service providers, and they provided the logistic what they needed in a discounted rate. So during follow-up, if they met the criteria of the quality as per the protocols, and they would certify them, they give the seal with the logo, and a very beautiful signboard, which would lit at night, and the people would know that this is the clinic which is providing quality services. So I think I see this as an example, and there are many countries who are now, the professional societies are gearing into that to give the quality of services. And now the government of Nepal has been working with the medical colleges to include into the AMA program, which is the again free services, and many medical colleges have enrolled into that. So once they are enrolled in that initiative, I think they have to follow the protocols and the guidelines, and I see that is the one step we go there. So if we provide, I mean, it's a kind of push to improve the standard services and the quality, and the government, private sector, public sector can go hand in hand to reach the goal which you wanted to reach in future. Thank you.
Thank you. I have one last question for Dr. Tegbar. Dr. Tegbar, you spoke a lot about healthcare providers and how Ethiopia has really scaled up, but could you tell me a little bit about how quality control and how quality is being managed with the human resources for health element over there, and how we're seeing the impact of that?
Thank you very much. That's a great question. In fact, for the last 7-8 years, the priority workforce agenda has been quality, because the rapid push to expand training has created challenges with maintaining and ensuring quality. And studies we conducted among graduates have also documented, the skill attainment of graduates is suboptimal. So obviously, I mean, in retrospect or with hindsight, this is an important question for any country embarking on, rapid expansion. How rapid should you go without setting the standards and maintaining the standards for ensuring quality education? Would it be just sufficient, to graduate nurses, doctors, midwives, and then, you put them? So, Ethiopia has been running a national licensing exam to assess readiness before receiving license. And if I tell you the latest pass rate for midwives, it's around 60%. So only 60% of new graduates were able to pass, the national licensing exam. That tells you a large gap and, potential wastage, after years of, training. But there are there are measures, that Ethiopia is taking. Ethiopia has established mandatory continuing professional development system, to improve the capability of healthcare workers who are in practice. There is work going on, to reform curricula, to improve faculty capacity, to strengthen clinical skills laboratories, to establish accreditation system. Effort is, that we need to make to assure graduates have at least, the essential competencies before they graduate. But, in Ethiopia, that has proved difficult. It's not just knowledge and skill. I think compassion and respectful care is also a challenge, and the government of Ethiopia has also prioritized that in its national, workforce agenda. Maybe another challenge is motivation. So, even if healthcare workers have high level of knowledge and skill, if they are not supported, if they are not well paid, and work in enabling environments, it's difficult to provide quality care. And in Ethiopia, there are several challenges. Yeah.
Okay, thank you. And I'm glad you're talking about respect because, as maternal healthcare providers, that's something we feel very strongly about. One last question, very quickly, Dr. Thakur. I'd like to ask, building on what we just heard, what role do you see the private healthcare sector playing in the next 5 to 10 years? How do you see it evolve? What do you think, from your expertise, is going to happen? And then we'll just find out.
I think the private sector will be full and central about moving affordable healthcare in its agenda. They will be full and center in providing new products and services and innovation. There's one particular area that I think, you talked about 5 years? So let's talk about 5 years and then 10 years. The 5 years, I think, is going to be an inflection point about digital health. All the tools and the knowledge we've got on reaching distant population with quality services at a fraction of the cost, all the data and information and the knowledge, I think the advent of AI is going to change in an amazing way the way we deal with, say, ultrasounds, newborns, and managing that. We're still tinkering on the edges. But 5 years later at this event, we should be saying 25% of the preventable deaths in maternal and newborn were intervened by digital health technology. So that's the 5-year plan. Wow. And the 10-year plan will be all around more women are covered for all services across the emerging markets. Those are the 2 milestones.
We look forward to seeing what AI will be doing in the next 5 years in the maternal healthcare sector. So thank you so much. Really wonderful panel. We've all learned so much today, and I think there's a little bit more that we're going to hear.
Thank you so much to our great panel, Neha, and all of you. If I go through all your names, I'll say it wrong. So thank you very much. That was a great discussion with some really provocative thoughts that I think got a lot of people talking and applauding. That's always a good thing in a panel discussion. So that was sort of a bigger, higher level thing, but we need to always remember that it really all comes down to the patient. So part of quality is making sure that healthcare workers interact well with the patient, the parent, the families of the patient. So we are very lucky to have with us Wanjiru Kihusa, who is the founder of Still a Mum, which is a nonprofit parent organization.
Good afternoon, everybody. And I do know that we are short for time, so in the next 4 minutes, I will be telling you why the biggest stakeholder we are solving for in terms of quality is the patient. My name is Wanjiru Kihusa, as introduced, and I am a mom who 10 years ago, lost a baby and went on to start a nonprofit that's called Still a Mum that supports parents who've lost a baby. And in the last 8 or so years, we have worked with over 6,000 parents. And what I want to leave you with today is that parents and parent organizations are your partners. So just to backtrack a little bit, yesterday we had Treasure speak to us very vulnerably about her experience. And just to say here that we don't share our personal stories for dramatic effect or to point fingers or any of that, but it is really for us to come to the table and see what are we doing in such an amazing way, what do the gaps that exist, and then to solve and iterate. So I'm extremely honored to have all of you here. I suspect I have been knocking on so many of the doors of people that I see here in the last 8 years to hear the voices of parents heard. And so I'd like to start by saying that parent organizations exist. They may not be formal in your country. In this case, in Kenya, we have been running since 2015, but they may not be formal in your country. They may just be a group of women and dads that come together to provide psychosocial support. For either, in the case of Still a Mom, it's for parents who've had a miscarriage, stillbirth, or infant death. And for the first 3 or 4 years, mostly that's all we did. And then we began to work in areas that have to do with trainings of healthcare providers on respectful bereavement care. And I want to just really appreciate the Kenyan government and the people I have had the honor of working with in incorporating respectful bereavement care as an essential element of respectful maternal care. So for starters, parent organizations exist. Number 2, they are here to add value and as a resource to the work that you are already doing. So if you have any access to them, reach out to them, have them give you feedback. And amazing enough, some of them are providers. You know, it's always so amazing when I shared my story of loss and the doors I'd knock onto, the people that gave me the best service would later share with me that they, as a provider, also suffered some form of loss. So they are with you, they are an amazing resource, kindly use them. And then I would like also just to share that there are several partnership points that exist, and what we see as challenges are great places for us to partner together. On the conversation about financing that Dr. Quinn talked about, I ran Still a Mom for 5 years without funding, out of pocket for those 5 years. And then I was supported by a private entity, Facebook. I was funded by Facebook for a year, and we had a beautiful, amazing counseling center in Nairobi, which unfortunately, at the end of that, I had to shut down and let go of employees, and then COVID came. And just to remind you that that would be a great place for you to partner. And I will say here that what was so refreshing was working with ministry officials who would come back to me and say, oh, we don't have funding, but we can give you space. Do you need a room to have your psychosocial meetings? And I'd say, yes, that's a win. You know, it doesn't have to be money. It could be figuring out what we can do with existing resources. The other would be just to encourage you to kindly have us at the table when you're making your decisions. If you have technical working group, I have been very honored and privileged to be part of technical working groups. Sometimes it's professional bodies like Midwife, and they're like, oh, would you love to come and have us discuss maybe a course we need to add in our curriculum on respectful bereavement care? We have had the amazing opportunity to talk about care for the caregivers, where we talk about compassion fatigue of our healthcare providers who are unfortunately losing babies and are expected to, deliver a new one in a heartbeat. So we are here to honor and support the work that you're doing, just to kindly ask that you have us in the room. And this is a big one. Like I said, I probably have knocked on the doors of the organizations that you represent. So for me to be here at such a major conference, that's already a win. And just to leave you, thank you very much. So like I said, because of time, I want to leave you with this one statement that parents, especially in the continuum of care, we are your partners. We are here to make sure that we are not pointing fingers. We are here to fix the system with you. We are here to represent sometimes the voices of other parents who may not say that loudly, but if you can find a parent organization, and incorporate them in whatever form of decision making, whether it be a toolkit, whether it be improvements you're looking to make, I'd like you to just be encouraged and find those parent organizations. We are here to be your partners. Thank you very much.
Thank you so much, Wanjiru. It's a really important addition to this conversation and a reminder of how many elements there are to quality of care. So thank you for that. I just would like to give a couple administrative points before we close for the day, which is first, I would like to apologize for the French translation French-English translation. We tried to be creative and use some great new AI technology. We love new technology, but sometimes it doesn't always work as well as you want it to. So, apologies. And I would also like to point out that what we didn't get to tell you was the answer to the question that we asked everyone as they came in the room today. And the question we asked was, what was the biggest need people see in improving, and I can't read my own writing, in improving quality. Oh yeah, improving quality. That's an important word. It seems like I've used it a lot, right? So what is the biggest need people see in improving quality? And the answer was prioritizing subnational needs and gaps. So I would like to challenge all of you who said that, and all who may not have said that, to go to the technical marketplace, which is happening now, and see what sort of new innovative things are out there that may help you figure out ways to make those priorities and help maybe solve some of your problems or think of new ways to go about solving, as I think we talked about even in our panel discussion too. With that, I would also like to issue a very special thank you to our special guest who is here today with us, Ngoza Sana Dlamini Zuma, and I apologize if my pronunciation was not perfect, South Africa's Minister of Women, Youth, and Persons with Disability. A very important VIP for us, and thank you so much for coming and attending. Thank you. We appreciate your presence. And thank you all for being here. Go out to that technical marketplace. If you want to talk to any of our panelists, any of the people that were involved in the discussion today, you can find them on the Drift app. Thank you very much.